last ones in between lunch and the next step. I'm going to talk about innovative AFib strategies, and at this point I'd like to also introduce my team. I'm no longer with the heart clinic. I've decided to become an entrepreneur also. I'm with Vivian van Boven, who pioneered AFib surgery, and Dr. Thomas Serm, who's an electrophysiologist from Hamburg. We have decided to start an AF clinic. So what options do we have in AF? Which minimally invasive options? Well, it's clear. For rhythm control, we have surgical and hybrid ablation, which are part of the guidelines right now. We can also do LAA closure before sending patients for a pace and ablate strategy. All this is based on data from 1998 from Michel Hasseguer, who documented that you can actually trigger AF by stimulating the ostia of the pulmonary veins, which led to the development of catheter-based treatments for paroxysmal AF. Jim Cox's work was from 1982, so some years before. But this has led to a rapid development of the usage of catheter ablation, and we see these are the number of procedures in Switzerland, not only for AF, but for all EP indications, and the number of centers, which are also going up on catheter ablation. So this leads us to ask, what is the driver of this? And there is some solid data that ablations are good. And I'd just like to show you 5 studies. I'd like to start with the recently published Cabana study, showing that catheter ablation is better than drugs. The STAR-AF2 study, showing that PVI is enough as an ablation strategy. The CASTLE-AF data showing that ablation in heart failure does better than drugs. And the FAST study from 2011, which now just was published with a 5-year follow-up in Europace, showing that surgical ablation is superior to catheter ablation in selected patients. And the CASA-AF, which really demonstrates that a hybrid approach, a collaborative approach, a heart team 2.0 approach is the best for outcomes. So if you look at this is the Cabana Trial, showing a clear impact on freedom from atrial arrhythmias over time for ablation when compared to drugs. The CASTLE-AF, which is a very highly discussed study, but in patients with impaired left ventricular function, we see again ablation versus medical therapy for death and hospitalization, or rehospitalization and death for any cause. It is pretty clear outcomes that a catheter ablation in this situation is better than taking drugs. And finally, I'd like to show you the STAR-AF trial, which is an interesting work because it's based on the surgical thought. They compared 3 ablation strategies. Number 1 is pulmonary vein isolation alone. This is what we do in cardiac surgery. In the second group, they did pulmonary vein isolation with some special catheter ablations. And in the third group, they did some lines. And they randomized the patients to these 3 ablation strategies, basically just to show that pulmonary vein isolation is the most important thing you need to do for patients with paroxysmal AF, and is the cornerstone of a persistent AF treatment plan. However, non-paroxysmal AF, persistent, long-standing persistent, and permanent AF are much more complex because they no longer rely on the foci, on these electrical impulses which cause AF, but they have scar tissue which lead to rotors, and they have drivers. It's much more complex and much more complex to understand, even more to treat. I just highlighted the name here, Hasseguer. These are the data from Michel Hasseguer's group. A 5-year outcome of catheter ablation in persistent AF is pretty poor. However, with the number of ablations increasing up to 6 interventions, they get to an adequate number of 50% freedom of AF at 5 years. But you have to consider that these are multiple interventions, multiple rehospitalizations, and patients are still on drugs. So what do the guidelines tell us? I'd like to show you the 2017 HRS ERA. So this is the whole, the American, Asian, and South American societies. Symptomatic AF, refractory to an antiarrhythmic therapy or intolerant to that. For paroxysmal AF in patients who have failed the catheter ablation or who might not be amenable to one, or who prefer a surgical approach. It's a 2B. Now for non-paroxysmal AF, it's a 2A indication for surgical standalone ablation in patients who have failed a catheter ablation, who don't tolerate drugs, who prefer a surgical approach. That's America. What's in Europe? In Europe we have the same choice of rhythm control therapy following treatment failure. So we have 2 catheter ablations, and after the 3rd ablation, the patient should be informed by an AF heart team that stands in the guidelines, black on white, to then decide if he has AF surgery, a rate control strategy, a hybrid therapy, which can also be ablation and drugs. So what can we surgeons offer? We can do a median sternotomy or a procedure from the side when we do a mitral valve or aortic valve and do a concomitant ablation. But I'm not going to speak about concomitant ablation today, because this talk is about new, innovative, minimal invasive treatments, and these are the standalone thoracoscopic procedures to treat AF. These are the tools we use. These 3 tools are known from open chest surgery. This is a bipolar radiofrequency clamp. We have a cryothermic probe, which we use for endocardial ablations, and the pen, with which we can ablate and also pace. And this is the dissector, which we use in the standalone setting. This is the lesion set we can apply totally thoracoscopically to our patients. It is a pulmonary vein isolation, but it's not only the pulmonary veins which are isolated, it's all the epicardial fat, it's the whole antrum of the left atrium. And we can do connecting lesions. Whether or not that makes sense or not is something we can debate further. And we can resect the appendage by either clipping it or stapling it. There's one randomized trial, that's the FAST study, some time ago. They took patients, 65% of patients who failed the catheter ablation. Mean duration of AFib was 7 years before they got enrolled, and 63 patients got a catheter ablation and 61 a surgical ablation, and they showed a pretty impressive outcome. Overall, 12-month outcome off antiarrhythmic medication for catheter ablation was 36%, and for surgery was 65%. And this is randomized data, and just published last week. I'm proud to say that Vivian van Boven, with whom I do these procedures, is part of this landmark publication. 5-year follow-up. We have 61 follow-up on 61 patients, 4 deaths, 5 deaths in the catheter group, so no real difference. However, there were 6 catheter ablations in the thoracoscopic group and 11 thoracoscopic ablations in the catheter group, so there's a crossover. Most importantly, this is what I want to show. At 5 years, we're still close to over 70% effectiveness. Freedom of atrial tachyarrhythmias, and most of the patients are off anticoagulation. So these are impressive results. This is another study which was also published last month. So there's a whole, 2018 and 19 is coming with a lot of data on these thoracoscopic ablations, standalone ablations, because this therapy is really coming and surgeons are starting to adopt it. This is from Nico Doll's group, who combined his data with Bart van Put, so it's a Dutch-German group, and there again, at 12 months, for all comers, over 75% freedom from atrial fibrillation and persistent AF. However, now an interesting finding was when they did the multivariate analysis, they showed that in-hospital AF was a predictor for worst outcome. And so if a patient has a relapse during his hospital stay, as if a patient has a relapse during a cath lab procedure, that is an indicator for worse outcome. We have always been told that there's a 3-month blanking period and that we must wait for 3 months before we can decide anything. This basically shows us that if a patient has a relapse, we need to take him back right away to find the source. And that cannot be done by thoracoscopy, that is done with a catheter procedure. Which leads me to the CASA AF study, where 51 patients with long-standing persistent AF, this is not a patient that electrophysiology wants to treat, were randomized to surgical ablation or catheter ablation with a crossover. Single procedure outcome showed in 1 year over 80% for surgery and 50% for catheter ablation, we know that. But the interesting part was the multiple procedure outcome is much better for both groups. So a hybrid collaborative approach between an electrophysiologist and a cardiac surgeon who knows the business makes a lot of sense. Another study from Groningen, also pioneers in the group, they did a hybrid one-stop technology, and they did a whole box. They did lots of measurements. This is the flow chart in a very Dutch and precise way. So showing this is the epicardial procedure, bilateral thoracoscopic approach, thoracotomy, or unilateral thoracoscopic approach. And then they went on to doing all these interventional procedures. What I want to show you is, in patients with a history of failed catheter ablation, so these patients have already been ablated, they have another thoracoscopic procedure, you get close to 100% if you use a thoracoscopic approach. Now I'd like to show you our data in Zurich. We assessed 69 patients for thoracoscopic procedures. We deemed 42 patients eligible for thoracoscopic procedures. 27 were sent for catheter ablation because they either had previous cardiac surgery, or they had paroxysmal AF, or they were just too low risk, and they went for catheter ablation. From the 42, during the follow-up period of 72 months, we had 6 redo procedures for relapses. And this is the outcome we have at 1, 2, and 3 years. So for persistent AF, 2 years, 73%, 1 year, 89%. And these patients are all off anticoagulants because we resect or clip the left atrial appendage. Now something else cardiac surgeons can do in a minimally invasive fashion is we can also look at rotors and drivers of these. And this is an image from a patient with persistent AF who came for a thoracoscopic procedure. The day before, we used his Medtronic vest, and the patient then goes to the CT, there's a mapping done, and this is what we found on the epicardium. And we identified this rotor, which the next day, during the procedure, we ablated. However, we weren't able to document what actually happened to the rotor after we ablated it, but the patient went on to do fine. So going back to the 1987 Cox Maze, pulmonary vein isolation as the cornerstone of the Cox Maze, but also LAA amputation. So the first guy to think about LAA amputation was this guy. This is John Madden, a general surgeon, who, and the other guy up there is Clark Hargrove, who the colleagues in the team know well. Clark interned with John Madden, and he published a resection of the left auricle in 1948 as a stroke prevention method. Now we have the PROTECT AF study, which gives us pretty solid data with a poor device but good clinical results. I was involved in the development of the clip for a long time, and these are the devices which now are here, and this is the latest, the Pro V2, and Max Emmert, who you will see afterwards, published this follow-up study on 300 patients with a follow-up of 8 years of patients with a clip, and showed that they have a 93% stroke risk reduction in regards to the expected stroke rate. However, in regards to LA occlusion, the LAOS 3 study, in which we participate also, has just finished enrollment. So we hope that in a couple of years we will get the first papers where patients have been randomly assigned to either catheter ablation, to LA closure, or not doing heart surgery. And now, because this is a surgical meeting, I'd like to take you 2.5 minutes to the OR to show you the procedure, the left-sided procedure. It's a bilateral procedure, so we start with the right and then we go to the left. This is the left side. It's one 12mm port and 2 5mm ports. That's not a 5mm, but we start by opening the pericardium, cauterizing the small blood vessels on it. It's a beating heart procedure. Patients have to be able to undergo a single lung ventilation. We open the pericardium just dorsally to the phrenic. Up here you see the phrenic, and you see the left atrial appendage, which is beating, and then you see the pulmonary artery appearing. So now the pericardium is open. On the left side, we don't need to suspend it. Now we can do the epicardial measurements. This patient already had 2 catheter ablations. So with the pen, we can sense and pace the pulmonary veins, all 4 of them. These are the low ones. And you see the scar tissue here on the pulmonary veins. And this is the EP procedure we can do. Next step is to encircle the pulmonary veins with the Lumitip. This is a light dissector. and it comes out behind the upper pulmonary vein and the pulmonary artery, and then you have to bluntly dissect it out of the fat. And sadly, when you see the light, your heart rate drops slightly because it's a good sign. When you don't see the light, that's not good. And then you pull out the rubber catheter at which end the clamp is placed. And now the clamp comes in. The orange catheter is just a bit thicker, and then here's the clamp, this bipolar radiofrequency clamp. And the only damage you're causing to the heart, apart from the dissection, is the ablation which occurs in the clamp's jaw. So if you clamp the esophagus with the jaw, you're going to injure the esophagus. But if you clamp what you're supposed to clamp, you won't injure anything. And while we clamp, we can measure the tissue impedance, and that needs to drop within 5 seconds, so that we have a transmural lesion, which has been documented in the animal lab. An additional lesion we do is a lesion from the upper pulmonary vein to the left atrial appendage, because once it is clipped, no electrophysiologist can go in there and do an ablation. It's a very difficult spot to get to. We've learned that from collaborating with the EPs. And last and finally is the placement of the AtriClip, which has made LAA procedures so much more straightforward and less dangerous. And it is really a straightforward maneuver, maneuvering the AtriClip onto the base of the left atrial appendage, so that you get perfect, or you try to get as perfect closure as you can from the epicardium, which is not always possible. And then obviously the result is, once you're happy, you release it, and then we can check on echo, 3D echo, and you see a very snug closure line. So that's the procedure. In conclusion, thoracoscopic procedures offer an excellent single procedure outcome. Staged hybrid and a collaboration with an EP are crucial to improve long-term outcomes. Our procedure offers low complication in skilled hands in regard to catheter ablation, and minimally invasive surgical ablations are an important adjunct, and I put my emphasis on that. It's an adjunct therapy and for septic cases, and a heart team-based indication and decision-making as mandated by the guidelines is crucial. And in Germany now, insurance carriers are asking, where is your heart team decision on doing your second, third, or fourth ablation in a patient? So I think this is something we need to embrace. For whom is endoscopic surgery? Patient who has had catheter ablation, failure, who has a contraindication or doesn't want it, and obviously previous cardiac surgery is a contraindication. So I thank you very much for your attention, and I look forward to receiving your questions.
Thank you, Sasha. I think you were very clear, and I can only share your thought. I am still convinced this is really something that belongs to the future. It's starting very slow, but will be the future, I am sure. Any question? Yes.
So Sasha, very nice presentation and outstanding review of the current literature. Could you comment in your thoracoscopic approach? You just make isolation of a pulmonary vein and no line of connection on the roof and on the of the left atrium?
Well, in 90% of patients, we just do the PV and connect the PV to the left atrial appendage. There have been cases where we did a roof line, and in some cases we tried a floor line, but it's very difficult to measure, to document perfect closure if you don't have a hybrid setting, an epi-epi surgeon electrophysiology setting. This is something we're working on, which we're going to do. I work with Wim-Jan van Boven, who has a big experience in this epi-epi approach, where they can actually document their transmurality. I believe the worst thing a surgeon can do is to do a unipolar line on an arrested heart. To do something where we don't know, where we cannot verify the endpoint. When we do an ablation endocardially on an arrested heart, I think this is the worst thing we can do to a patient, because we cannot document whether or not we have achieved a transmural lesion. That's why I think we should only do things which we can verify.
Yes, that's for sure. And because I have the feeling, I don't do run procedure, I just make concomitant and with the atrial also.
Mm-hmm.
And I have the feeling that when you make a complete box, and when you clamp the roof and the bottom of and the floor of the left atrium at the time, as a complementary measure of the VP isolation, that we are more efficient.
You're totally correct, and Ralph Damiano's data had documented that a complete box gets better results. However, we cannot do that off pump. We're in a beating heart setting, so we have to use other unipolar devices to make a whole box. Ideally, we would make a box, and the EP would additionally check it and make endocardial lesions.
And Sasha, how many lines do you put around the? How many lines?
How many do you do when you do a?
Two.
Two. Okay. Well, a lot of people do 1 or 2 or 3. We do it between 8 and 15 times.
Wow.
Yeah. We wait for the impedance to drop within 5 seconds because we've seen that if you don't do it completely, you will have some epicardial reconnection. So this is, my colleagues always say when I'm standing there doing it, they say, stop it now, you've done it. Let's get on with the case. And it's always interesting because I say, no, this is my little part. And that's how I learned it. And we learned that within 5 seconds it has to drop. Then you have no more water in the tissue, and the proteins are completely denaturated, and you have a transmural lesion.
Nice talks, nice talk, Sasha.
Thanks.
And obviously everybody has the same problem, getting the patients referred. And as I know from multiple talks with electrophysiologists, most of them, they say, we don't need you. We do it 6, 7, 8, 9, 10 times. And then I come back to the whole philosophy of what Roberto said just at the beginning of this fabulous meeting. And that is really one of the biggest obstacles everybody has all around Europe, as I know in Germany, also here, that you get the patients which have been ablated for unmeasurable times.
You're completely right. However, the world is changing, and we have the internet, we have artificial intelligence. We also have patients who become more informed. My father is 80 years old. He has a tablet, he has a smartphone. He goes online and critically looks at medical diagnoses. And I have a bunch of patients who are finding me now over the internet and who actually ask, hey, is there an alternative to the procedure I have to do 2, 3, 4 times? And it's going to take off, I'm sure. I'm not worried. I really think that the internet, the smartphones, and patients becoming more involved is going to change the course of the referral patterns. Thank you for your attention.
Thank you, Sasha.